Welcome, welcome, welcome. You are now part of the Q&A session of the program. Oh, it's coming to an end, y'all. I got to put my glasses on so I can read and get us right here. We're almost, I'm so sad. We're coming to the end of this time that we've spent together. I hope you've enjoyed exploring this virtual environment and the opportunity to have the breakout sessions. And before we welcome the panel, I have to go over a little bit of how the Q&A session is going to work. Right? So when you registered, we asked you to put in some questions there. And during each of the program session, our beautiful people in the background have been taking some of the questions and we've been keeping them so we can ask some of them here today. We only have 45 minutes, y'all. So this is to the people out in the audience world, but also to the speakers here. Keep the answers tight. Right? Because if you go really long, that means somebody's not going to get to a question. So I'd like to introduce the amazing panelists that we have here today. You've already heard their bios, so we're not going to do that right now. But we have Dr. Sanders, Dr. Darius, the amazing Lisa and Mark. I serve on a couple of committees with them. Welcome, all of you, to the breakout session now for our Q&A. Thank you all for being here. Look at all the smiles. Mark will be joining us, y'all. He's having a little bit of difficulties. If he gets here, we'll just add him in. If not, we'll keep him in our love. So we talked about research. We talked about self-advocacy. We talked about MS below the belt. That was all of them were good and family. I'm going back and forth between the sessions on my iPhone and my iPad and my Mac. I'm trying to listen to all of them. Just all of it has so much energy. Lisa, I'm going to come to you first. There's so many questions here, but there's a question that came in from Patrice that she asked, how can she communicate and advocate in a really positive manner without seeming like she doesn't trust her healthcare provider?
All right. Excellent. Thank you so much. Listen, it is my pleasure to join all of you. And I think that is such an important question. And my response is, you have the right to ask any question about your health. That is your time. You are paying money. You're trying to receive resources to ensure that you continue to improve and progress with your health. So one thing that I really recommend, I actually saw on the resources page, there is a Living Well guide, a guide for Black Americans. And there is a section that has notes, questions for your doctors. And I think it breaks it down, very well. Make sure that you come prepared, you take your notes. I think whenever I, come into a meeting, and I know now I'll keep it really brief, I come in with my questions, I come in with articles, I let them know that this matters. And then I think they do take me seriously. So I think as long as you do your research, you have your notes, questions for your doctors, and prioritize which questions you want to ask.
That's the key part.
They should respond
prioritize. Yes,
they should respond favorably to that.
Yeah,
if not, it's time to consider looking elsewhere, to be honest with you.
Don't be afraid to switch doctors. I've done it many times. Don't not be afraid. Dr. Sanders, I'm coming to you next, and then Dr. Darius. So we had a lot of questions about MS running in families. As some of you may know from the conferences, I have MS, my sister has MS, my auntie has MS, we MS family right here. So how likely is it, though, that MS passes on to our children?
Thank you for that question. And this has been an awesome experience for me. This is my first year doing it. And so I hope to participate in the future. That is a very common question that we get is how common or how likely am I to pass this down to a family member? And I will say that genetics plays a role in the susceptibility of developing MS, but it's not the complete picture. So when we look at identical twins who share the most of their DNA, if one twin has it, the other twin has about a 35% likelihood of developing MS. That is definitely higher risk than the general population, but I always counsel my patients that you don't pass it down necessarily like your height or your eye color, but yes, there is a genetic component to it, and it is something that if you have a child who is developing symptoms of MS, they should get checked out. However, there's no need to preemptively or proactively go looking for it.
That's the main question. Now, a follow-up to that, lots of times people say, should you go ahead and start giving your kids like vitamin D early on, regardless?
So there's a small study that suggests that obviously we know vitamin D deficiency is correlated heavily with the susceptibility of developing MS and even the progression of the disease. And there was one small study that looked at pre-treating your children with vitamin D. I would ask their pediatrician to check their vitamin D levels first. I think it's important to know if they're deficient or have an insufficient level before supplementing it, because sometimes too much vitamin D is not good as well.
Okay, that's good. That's good to know. Look, I got my vitamin D on my desk. I take it every day, y'all. Do not play with my vitamin D. So, Dr. Darius, let's I see you, Lisa, snapping your fingers. I see you. So, I'm going to come to you. There's so many great questions on the talk around MS below the belt. Like, I'm going to go back and listen to it several times. But there's some suggestions around approaching sensitivities like sexual health, incontinence, mental health. Like, what suggestions do you have working with providers?
So it kind of goes back to what Lisa says. When you're going to see a provider, especially with those specific topics, it can be for the patient, they can feel embarrassed, they can not necessarily know how to broach it. You're the patient, you advocate for yourself. So you should have your questions, your concerns, have all of the information that you've kind of picked up, and then bring it to your provider. Remember, when you're seeing your provider, even though we hate to say it, we have a specific time period that we can crunch up. We're trying to crunch up 4 hours worth of discussion into 30 minutes to an hour if you're lucky. So you want to make sure that you have all of that information there. You have your priority questions. And specifically when you're talking about MS, below the belt issues, if you are a female and you know yourself and you're not going to feel comfortable talking to a male neurologist or a male urologist about it, I am a huge proponent of changing a provider, just like I change shoes. I said it in the discussion before. When you're going to buy shoes, you don't buy it just because it's cute. It has to fit as well. So you want to make sure that your provider fits who you are and you feel comfortable with them.
You know what, Dr. Darius, I'm gonna expand on that just a little bit for you, and then I'm gonna come right back to you, Dr. Sanders. This question is joint between the two of y'all. When I was listening on the session, there was a beautiful soul that talked about her doctor said she was too old. You're a little old. You don't need to worry about sexual continence. Look, I'm 53. I'm going to be worried about it until the Lord takes me from here. Right. So when you want to talk about that, because right after that, Dr. Sanders, I'm going to come back to you around some bias around maturing and this disease.
And so when she mentioned that, I was a little bit thrown aback. Sexual health has nothing to do with age. Some of the highest STD rates are in elderly adults because of the misconception that the elderly doesn't get down. So, and I explained to her the same thing. I kind of said, at that point, she may need to find a different provider because that provider is no longer fulfilling her need. It has nothing to do with age when it comes to being comfortable sexually. And then you throw on top of that a chronic neurological condition that has ups and downs. So you need to feel comfortable with someone. If you don't feel comfortable with someone, you're not going to tell them the issue. And on the provider side, we need to know the whole picture so that we can give you the best possible recommendations for an optimal health outcome. So I'm interested to hear what Dr. Sanders has to say as well.
Yeah, Dr. Sanders, will you expand on that a little bit and then add to it? There's a question around, do you feel like there's bias regarding as people mature with this disease and the research that's being done on MS and aging? Can you talk a little bit about that? And then Lisa, I'm coming to you next.
Oh, definitely. I agree. And I echo everything that Dr. Darius just said. It is definitely something that we have to keep in the forefront when we're talking about multiple sclerosis and below the belt issues. That sexual health and sexual awareness is definitely at the top of the list, no matter the age. I do think, though, that as a lot of data, a lot of research is really focused on the relapsing remitting disease, the early MS, because we know early diagnosis means early treatment means we do much better at the end of the journey. There is, though, some growing data looking at what happens to a person's body as they get older. One thing specifically that we are looking at, or there's a study that's just completed, is looking at whether or not disease-modifying therapies are necessary as a person gets older. So we initially felt that patients would be tied to their DMT for the duration of their life, but we know that the body changes as it gets older, and that includes the immune system. We know that the immune system becomes less inflammatory. So we call it immunosenescence. And so there may not be the need to continue with these sometimes powerful immune suppressant or immune modulating therapies when we have to balance the risk of infections that can come along with them. I think the other thing that occurs in the aging MS journey is the likelihood of or transitioning into secondary progressive MS. So I think that kind of maybe where that question is coming from is what research is looking into slowing down the progression in people who have transitioned into secondary progressive MS. It's the research is not as robust in relapsing remitting MS because it's a little bit easier and faster to study. But there is definitely research studies looking at ways to slow down the progression, maybe promote remyelination that can also help as a person gets older. But that's the jury is still out on that one.
So, Dr. Sanders, can you expound on it just a little bit? We have a question that's come in around how do you know? How do you know when these disease-modifying therapies are working? Is it no new lesions? Is it no new symptoms? Is it both? Is it, how do you know? Because I was telling my neurologist a couple of years ago, I think the disease has left my body now. And he was like, no. I was like, but I haven't been sick for a while. And then literally 3 months after that, I had one of the worst exacerbations I've had, came out of nowhere. So how do you know?
Yes. So I'll start off by saying that we know that our disease modifying therapies are not cures for MS. I think it's important to understand that. But these clinical trials that looked at these disease modifying therapies do show that they reduce the likelihood of having a clinical relapse. They reduce the likelihood of having new lesions on your MRI, which can occur in the absence of having new clinical symptoms. And they do have a modest effect of slowing down disability progression. So you know that this medication is working for you. If you've not had a relapse, your MRIs are stable and your daily function remains the same. If any of those things change, that might be the time to have that discussion with your healthcare provider on whether or not needs to be a switch in your therapy.
That's good to know, yeah. And I've switched several times. People say, what medication are you on? I'm like, this is what I'm on. But my sister has MS as well, and we don't ever have the same symptoms. So you have to do what's best for you. Lisa, I want to come to you now because there's quite a few questions around how do you disclose? How do you tell your employer? Do you have some advice on how you go about doing that?
Okay, I think that's but I've definitely had some time in my career where I had to, really consider when was the best time for that. I would have to say I do think something that's really helpful though is at each site, or usually at the place where you work. There should be, an employee relations, some support that can give you some advice on how to go forward. I mean, it depends on, do you need a change in your accommodations, something along those lines. A great and excellent top resource that I was introduced to when I had to start considering that question was the Job Accommodations Network. So that is askjan.org. And it has every question, every little bit of information that you might need. Also advice regarding legal assistance. So they have chronic illness from A to Z. You type in what your chronic illness is, and they give you a listing of some potential reasonable accommodations. But it is, I think it depends on the individual, but if it gets to a place where you do have to get some support, then I think it's time to start, coming up with a plan on, when to start, divulging and sharing that information.
Yeah, don't you think, Lisa, and for any of you, please answer this. I ran a support group here for years, like 15 years, and there was a number one question, like, should I disclose? And I always say this is very personal. It depends on where you're working. And I was very careful of like, yes, everybody should disclose. It makes you feel good. And I disclose, I'm very authentic about it. I have several people that I know that work within our company. I work for a company of over 140,000 employees. And I know several that don't disclose for various reasons. What's your opinion on it? Let's go with you, Dr. Darius, first. Do you have an opinion on that?
Yeah, so it definitely goes with the comfort level. And then a lot of people fear the backlash of like, if I disclose my diagnosis, then I feel like I'm going to be targeted by my specific employer. So it really is based on their comfort level. We tend to kind of educate them on the pros and cons. So if you do have an exacerbation, having an FMLA form or submitting a disability form, it will cover you for that time. So if you need to get your monthly Tysabri infusion, or if they need to know twice in a year, you're going to need to get infusion every 6 months for whatever it is that you need to cover you for that time, or if you have an exacerbation. A number of the patients that I've dealt with, again, they are reserved in doing that. But once they have a really bad relapse, unfortunately, it takes that one bad relapse for them to say, okay, I need to divulge this information. And we try to prevent them from the best that we can. We try to educate them and prevent them from having that one relapse before they actually say, yes, I need to do disability or FMLA or anything like that.
As proactive as you can. Go ahead, Lisa.
What you would say with the FMLA form, you are not required to divulge what your disease is.
Correct.
So you can still take your time with that.
And so I tell them, those who do FMLA, I say, we don't necessarily have to say patient has diagnosis of multiple sclerosis. I usually put patient has a chronic neurological condition that has episodes, flare-ups, may occur every 2 to 3 months, just to kind of cover the time frame. Even if the patient is stable and hasn't had a relapse in years, it's just to be able to cover that time for them if it were to occur or if the situation were to arise. So I'm very vague if the patient doesn't want me to say specifically that they have MS. I'll just say neurological condition and blah, blah, blah. Like describe it as vaguely, but as specific as I can.
That's very helpful. That is very helpful for the individual. So then it gives them time as they're considering. I have to say I was very fortunate that at my last neurologist when I was at Berkeley, she actually had a social worker employed in her office. And she, that social worker was very, supportive and provided good information. And I have to say, I did come from the birthplace of the ADA, right? So Berkeley, California. But even with that, I still was very careful. And deciding when to, let my employer know. So thank you for asking that question.
Yeah, Dr. Sanders, I'm going to let you offer anything you want to on that topic. And then I have several questions that will come in for you. So I'm going to try to pull them together.
Okay. No, Dr. Darius, I do exactly what she does. It is definitely a personal decision. It's the person who knows their employer, who knows their HR department. Obviously, companies are different in size and flexibility. And so I leave it up to the patients to make that personal choice.
Yeah, I really do. Okay, so now we're getting into some details, and I'm going to kind of keep them at a little bit of a high level because I know I've talked enough on panels with doctors that are like, the non-disclosure. I'm not going to answer that at that level of detail. But here at the high level, and I'm going to ask this to you, Dr. Sanders. Dr. Darius, please chime in as well for some of these. So the first question is there any advice that you should have, either of you, on keeping cool being intimate? See how I changed that up?
So my first thought, I'll be transparent. My first thought was the fan, but I don't think that's going to work good No, I think as we all kind of battle intimacy, whether we have MS or not, being connected with our partner can help to facilitate those instances where it maybe become too warm. So there may be different positions that might allow for a little bit of more of an airflow and space in between where you can kind of stay cool. I'll throw out there, it doesn't sound too sexy, but maybe putting on a cooling vest, during that time as well, if it's important. And I think if your partner cares about you and you can work around those types of things, obviously staying hydrated before and then after are ways that you can stay cool on both sides. I don't know if Dr. Darius has something else to add.
No, I was going to say, I was definitely going to mention the cooling vest. It may not look, you can probably bedazzle it up a little bit, make it a little pretty.
On it.
Right. But I definitely was echoing some what Dr. Sanders says. Yeah. You can actually try to the fan as well. If you have a cup of ice, like she said, staying hydrated or actually utilizing the ice, however it is.
What works for you,
whatever works for you. Make fun with it. So yes.
So we have another question that's come in.
There's nothing wrong with fans. There are nothing
wrong with it. That's right, Lisa. Nothing wrong with a good fan. A good breeze. Nothing wrong with it. And somebody said also the swimming pool is good. Just have your equipment in. I don't know who said that. The shower. Look, I'm getting all types in right now. Okay, so let's go to this next question. This is for you, Dr. Darius or Dr. Sanders. So there is Janelle's experienced some legs. How do you say this? Spasticity?
Spasticity.
Am I saying it right? Okay. And wonders if Botox can help. Uh-oh, look at both of y'all's faces. No?
Yeah, I think. So there's different, and I know this was for Dr. Darius, but if you're okay with me jumping in.
Yeah.
So there's really different severities of spasticity. Okay, so there are muscle spasms, but then there can also be fixed muscle tightness or increased tone. It depends on the location, the number of muscles that are involved that directs the treatment for it. So I tell patients if they're isolated muscles, if they're small muscles, we can target Botoxing for those. That's mostly like finger flexors or elbow tightness. But if we are starting to see spasticity involving large groups of muscles, both lower extremities where those muscles are huge and we don't have enough Botox to get those loose enough. There are other ways in which we can target that spasticity, including oral medications such as baclofen. There is the possibility of doing intrathecal baclofen, which is a pump that puts the baclofen in the spinal fluid. Those are much more helpful when there is more of a widespread spasticity, but Botox is FDA approved and an option for focal areas of spasticity.
And also medical marijuana for certain type of patients have found that to be helpful with their spasms. Again, it's the benefit of the larger area of spasticity. Not sure, and more research needs to be done. But I've had plenty of patients who come in the clinic and say, having marijuana has really helped with their spasms.
You know what? My sister believes in MS, has an MS physical therapy group that she goes to, has made a huge difference with that. And then somebody posted CBD may also be helpful.
CBD.
And I found that as well. I'm for anything that helps you, do that. Do that. Okay. So I'm so nervous. We're coming up soon. We're going to have to be closing out. Okay. So I have some questions. I'm going to just open this first to you, Lisa, but anybody please respond. There's a lot of questions around family, right? We have 20. Oh, John's telling me we got 20. Thank you, John. Then we have 20 minutes off. Okay. So how do I help myself not get disappointed with family members that may not be supportive? Lisa, I'm going to come to you first, but anybody chime in.
Okay. Wow. Yeah, I appreciate that, family. Here we go. Oh boy. And I happen to know that I have family watching, and I love you all very much. So, so yeah, this is an adjustment process. I mean, as you're, the person with MS is making some changes in their lives. They are transitioning. They are different than they were previously before being diagnosed. That comes with an adjustment for that individual, for that person. And then your interaction with individuals also, plays a part of that. So they are adjusting to getting to know you, a different individual. So you have to be patient with each other. And then there are times, I have to say, that there are individuals that, sometimes might not be as understanding as the question was raised regarding, maybe your fatigue, different symptoms that are impacting, what you said, your commitments, et cetera. And so you just have to adjust, or if that individual doesn't seem to understand, you do have to be okay with saying maybe we're not going to be able to continue at this time, but continue to work with each other as time goes on, if that makes sense. Mm-hmm. So that is something that I've had
to do. You got to do that with family too. That's what I'm hearing you say, Lisa. Family too. Sometimes you have to cut family and be like, hey, I don't have that with my family. Yes, friends. Yes, yes.
That might not understand. Does that make sense? Might not understand your symptoms.
Yes, to add on to what Lisa was saying, I find that most of the issues happens with the invisible symptoms, where the fatigue or the bladder or the emotional, the depression, like when you have the physical symptoms, when they see you limping around, or when they see that, you have a cane or a walker or you're in a wheelchair, they tend to kind of, in their mindset, it makes sense. They tend to understand that more, as opposed to if you say, I'm just really tired. I really can't go clubbing with you today. Or I really can't go grocery shopping. Or no, I really don't feel like going to dinner because I'm really exhausted. Because they can't physically see how overwhelmingly exhausted you are. They don't tend to really understand those symptoms that they really can't equate a physical connection with. So I tend to tell patients that your symptoms you're having, they're real. They're real to you. You're having those symptoms. You need to express in an open way. Just even if they don't listen, for you to just say, look, I know you can't see this fatigue that I'm feeling, but I'm really exhausted. And if you can't understand that, then maybe this is not going to work, because bottom line is the stressor that you're adding to me is going to exacerbate these symptoms. So that's where I really see a big disconnect. It's not necessarily those physical MS symptoms. It's really with the ones that they can't actually see that the patient is going through.
So you nailed it. I just want to say sometimes those invisible symptoms. So for example, insomnia, which is what I have, will have an impact, a negative impact on the more visible ones, on my mobility. So lack of sleep has a negative impact on, your ability to do some of your other activities. So I really appreciate that, Dr. Darius. Thank you.
Dr. Sanders, do you have anything to add?
Yes, I was going to add, depending on how close that relative is to you and how much they are needed or desired in your activities of daily living, bring that person to your doctor's appointment. Let them see your MRIs. Let them hear the doctor talk to you and have that discussion with you. I've had several couples in whom, once the husband came to the visit, they finally understood what their wives were going through.
Mm-hmm. That's very helpful, Dr. Sanders. Excellent. Yeah. Thank you.
And I think the more people, you don't hide so much, at least with the intimacy of who's in your household, right? Whether that's your children or your significant other, then they can be willing to help. But the other thing is, and I'm bad with this myself, is you got to tell people what you need. I need some help. You have to ask for it, because otherwise people don't know. Dr. Sanders, okay, we're getting a question in around bladder. And does the bladder affect ED erectile dysfunction is ED, right? I'm not a doctor, but I'm just assuming. Okay. Can you respond to that question?
I didn't unmute myself. So I don't know if it necessarily one affects the other, but they have a similar cause. So we oftentimes will see, particularly in our men who have bladder issues, they also have erectile dysfunction. And so I think it's the same communication of those nerves going down into that area. So we do see them in combination, but I don't know for certain, and maybe Dr. Darius knows, whether or not one actually causes the other. I think they just go hand in hand.
I agree.
That was good. Okay, that's the end of that. All right, next topic. First of all, let me shout out the MS Navigators. They are rolling in the audience chat. So if y'all have questions in there, I'm not even having to ask some of them. They are on it. I'm telling you, our MS Navigators are amazing, and have there. So use them, utilize them so much. Okay, guys, here's a question around, this is the Black MS conference. So let's talk about Black people for a second. Is there a difference from what Black people experience living with MS compared to others? Dr. Darius, Dr. Sanders, and Lisa, but I'm gonna go to the doctors first. Would one of you like to answer?
I'm going to answer from like a socioeconomic standpoint. I think African-American patients tend to get diagnosed later, and so their disease process tends to be more aggressive. And also, there are not a lot of African-American clinicians in the MS world, let alone neurology. So, Dr. Sanders, you can attest to this.
We all know each other. We all know each other. We're all. That's how little there is. We all know each other.
And so just think about those people who live maybe not necessarily in the Baltimore area or not in the Florida area, but live in Utah or live in Michigan and things like that. Some patients do want to see someone who looks like them, who can kind of help navigate them to the disease process. And there's not a lot of African-American providers in MS. So I think that is, a big, not necessarily a disconnect, and it's disheartening to Black MS patients, because sometimes they'll go see a provider and they have other socioeconomic issues that they just don't feel that provider can relate to or can really understand. So Lisa,
well, I just
Dr.
want to say,
Sanders,
I've read, is this true, Dr. Sanders, that it's less than 3% of Black MS specialists and about 8.6% Latinx MS specialists? Ms. Michelle Witherspoon, I might have something to say. But I understood, of course, the doctors, naturally. But anyway, I do recall my,
Lisa, I know you have to. She is a researcher, y'all. She will research. I'm on different committees with her. She's a plethora of knowledge. But Dr. Sanders,
joking, but that's I know, girl. To that. No, this is a family here, right? So just wanted to add some levity. But I appreciated Dr. Darius's mentioning of, for a sociological standpoint. I mean, just your experience of what it's like to go into a doctor's office and being treated, just the whole, we know this implicit bias and just having the absolute need of having someone come with you, because they do change their behavior. I mean, I've sampled it, I've tried it out. I've also noticed sometimes there's differences. Almost always the people that I bring are also people of color and women of color. And, some of the healthcare professionals still will react as if, it doesn't matter. There's two of you. That's, that doesn't change my behavior, essentially. But then that's time to change, right? I mean, if you notice that you're not being heard, then it's time to change. But that, I really appreciate what you're saying about having, the need to address the sociological factors. So, another thing is just very quickly around that. I mean, I think it's, just reading and then also from, experience, the need to have some tools, more tools in your tool belt, kind of code switching and having to use everything you can. I mean, reading, this, I think this is in Momentum. One individual said that, she has to wear her brown sweatshirt and her father always wears his, Columbia. I told my friend to make sure that she mentions that, she may be even on here. My line sister that, she has her doctorate from Harvard, and sure enough, her neurologist, after seeing him for years, responded differently. And that's unfortunate, isn't it? Yes. But you have to use everything you can to get what you need. It is different for us, for us at all times.
In a variety of ways. Yeah, Lisa, I agree.
I'm sorry.
Yep,
that really is
No, I appreciate it. Dr. Sanders, I'm going to let you answer that, but can you piggyback on another question that's come in today? There seems to be a little bit of confusion. Is MS inherited? Do Black people experience it more? She said she heard a little different from what she's hearing at the conference compared to what her doctors are saying. This goes back to the broader, there are Black people experiencing it differently, and we touch a little bit about hereditary.
Yes. So I was going to mention, aside from the socioeconomic aspects, and we kind of touched on it briefly in the MS research breakout session, is we have limited data about how MS affects the Black community. But from the information that we have, we do find in those small studies is that African Americans tend to have more optic nerve and spinal cord pathology. There tends to be faster and earlier progression that occurs in our African American community. They tend to require the use of a cane a little bit faster than the Caucasian counterparts. And so we also see more relapses and poor recovery. Whether or not that is the story for everyone, that still needs to be figured out. But from the limited data, that might suggest that MS may affect African Americans more severely and more aggressively. We also know that the African American female is probably the most likely to be diagnosed with multiple sclerosis from the data that we know, almost 3 times more likely than the Caucasian counterparts. And so figuring out where that difference is and what is the cause, is it genetic? And I'll loop back to the hereditary type of the question, whether it's environmental, socioeconomic, there are many factors that can come into play at why these numbers appear as they are. And we're still trying to tease that out. So I made shout outs to Dr. Williams earlier about her quest to increase MS research in the African American population. You might hear, going back to that hereditary question very quickly, you might hear differences in what your provider says and what you hear about on seminars. It all depends on the knowledge of your provider. Not everyone that treats MS knows MS and knows really the nuances around it. So it's important that you get your information from all different sources. So I applaud you for attending this seminar so that you can glean different information from other providers. Not to say that your provider doesn't know what they're talking about. They may not understand the nuances between the genetic aspect. But yes, most patients that are diagnosed with MS don't have a family history. But as you can see with Michelle, it can definitely have a genetic component to it.
So, Dr. Sanders, while you're talking, we're just getting, I think once they start, people trust you and it's a safe environment. So we're getting some questions coming in around research. And Dr. Darius, I'm not sure, or Lisa, if you know, you can chime in. So I don't want to leave you out, but there's some questions around the research happening around myelination. Is it repairing the myelin? Where are we with that?
Very early studies. Very, very early studies. I'm not aware of any human studies that have identified an agent where it is targeting either active remyelination or promoting your own body's mechanism to remyelinate. I think we are gathering some information in our animal models, maybe some in our ophthalmology counterparts as well. But I don't think, though, that there is any large phase 3 studies that are looking at showing that it actually helps.
So I was going to say, I do know that, and it is targeting the optic nerve. There is a nano gold particle study that is in the works of being started at Hopkins. There's some other studies that are going, but very vague. But these are like early on. But the nano gold particle is one that is targeting optic nerve kind of remyelination of the optic nerve. So it's a vision study.
Can you answer really quickly? I want to be part of that one. I've lost my eyesight 3 times. In like 30, 60 seconds or less, because we're coming down to 4 minutes, what about stem cell research? Is there anything happening around MS and stem cell research? Uh-oh, why are you smiling, Dr. Darius?
It's a slippery topic for me. And I know that with a lot of high profile actors and actresses who have done stem cell, a lot more people are kind of asking a lot more about it. But for me, I don't know how Dr. Sanders or Lisa, how you feel. For me, it's still like a slippery slope, and I still feel like the risk outweighs the benefits, if there is any.
You know, I think stem cell transplantation is probably the biggest immune suppressant therapy, right? Because you're taking medications to ablate your immune system and then putting the stem cells in to reactivate it or to put it back in. I think we've made some advances over the years. I think the safety profile of stem cell transplant has definitely declined over time. It's not as risky as it was or as deadly as it was years ago, but I encourage my patients to seek it within a clinical trial setting. Today is not the time to go into different countries and get their stem cell transplant until we really hash out all of the ins and outs of it.
Are there any other breakthrough therapies that you would say, this is a good one, we need more people of color to participate in this particular study? Are you aware of any other breakthrough studies?
I'd say go participate in all of them, but you know, or in any of them. But yes, there are a lot of therapeutic trials that are looking at other mechanism of actions. I know that there is an increased interest in another molecule called a BTK inhibitor, where it kind of targets the effects of B cells a little bit different than what our agents that we have available now. And so, yes, call your doctor, ask them, is that available for you? There's clinicaltrials.gov, and that you can go and research and see what active clinical trials are available. But I would say talk with your healthcare provider because they may know what's available in your area.
Yeah. Add on. I know I have a lot of patients who tend to say, oh, we're not represented in clinical trials. But then when we tell them about a clinical trials, they don't want to participate. So you can't complain about not be represented in them if you're not actually participating in them. And with the whole new push with precision medicine, we do need more African-American participants in these trials so that we can, what's the word I'm looking for? Gosh, it just blinked. I just had
help with our,
but basically so that we can be able to target specifically, you know, what may be different in the African-American person's disease process compared to, you know, your white patient. So what specifically will work for you? And we are underrepresented in research studies. So we definitely do. I was a research nurse at Hopkins for almost 7 years, and getting people to participate, particularly Black people to participate in the study at Hopkins, which has a whole other history. They're kind of like, I don't know about this. I'm not sure. I want to do this, but we do need Black participants so that you can be represented in the actual outcome of the treatment.
So family, we're coming to the end. And so I just need to close this out really, really quickly. We're right at the top of the hour. And so thank you all for joining us through these last 2 days. It's been amazing. Listen, this doesn't have to stop here. So this platform is going to be open into the end of the year. Make sure you go to the lounge. I was in there on breaks. I signed up personally for the CHIME study. I signed up for 3 clinical trials during the break. So do it. Take care of it. Before we go away today, you can see the MS navigators in there doing their thing. So you can always go to the MS website, go to nationalmssociety.org, or there's an 800 number, 344-4867, 344-4867. Call them anytime. Remember, the MS Society's website has a whole section for the Black community. We've worked hard for that part to be included in there. It's there. They believe in it. So much stuff there. Volunteering, advocacy. We need your voice on the Hill. You know, how do you show up for other things? So do that. Make sure you also join all the rooms. There's a Facebook room. I joined that last night through the Resource Center. There's all types of stuff there. Family, we love you. Thank you for joining us. As Don Cornelius says when he leaves, we wish you love, peace, and soul.
Good job, Michelle. Well, thank you very much, MCs. Wonderful work.
Bye, everyone.
Thank you, everybody.
Bye.